All right, guys. I see y'all getting signed on. I think you should be able to hear me now. I think my audio wasn't working. Good deal. Thank you, Paula. I just want to let you guys know everybody's lines are going to be muted. We've still got a few more jumping on. We're going to get started here in just a second. Handouts for this, if you want to go ahead and print out your slide deck, handouts are in the handout section. You should see a PDF file for these slides. If there's anybody not able to be on today, we will send out a YouTube link for this presentation as well as the slide decks afterwards. All right, see y'all getting on. Got a couple more jumping on here, and we'll get going. All right, and again, just remember all lines are going to be muted, and those handouts are in your handouts section of your GoToWebinar pane. All right, since we don't have a lot of time today and a lot of information, we're going to go ahead and get started on this, guys. My name is Melissa. You have me today instead of Teresa. And we are going to be talking about the 2018 quality measures. I know you guys are super excited about that. We've just barely put 2017 to bed, and already we're jumping right into 2018, which, you know, is great because that way you don't have time to forget anything, right? And the most exciting thing about 2018 is, especially for those of you that have been in the ACO previously, is that all the quality measures are the same this year. Nothing's been added or deleted, same 15 measures. There are a few small changes we'll talk about, but even for those of you that were not in the ACO last year or new this year and did MACRA, these quality measures will be easy for you guys as well. Nothing that can't be captured, you know, in a patient's annual wellness visit. So I'm going to breeze right through a lot of this information for you guys. Some of it should be overview. If you do have any questions, we'll try and catch those at the end if we have time. Otherwise, shoot Teresa and I an email or a text message, a phone call, and we'll handle questions on a one-on-one basis. All right. So let's go ahead and jump right in, okay? So housekeeping a little bit here. Like I said, those slides, we'll send out the slides and the YouTube later on, but you can print out the slides in your GoToWebinar window pane. We're going to do a brief little overview, talk about the changes from 2017, and look at those quality measures, all right? So why are we doing all this? At the end of the day, really we're doing this to meet our MACRA and to meet our ACO measures. Ultimately, you know, we want to provide good care for our patients, but we can't do that without the revenue. And it's 5% in your pocket this year, guys. That's really all there is to it. We're doing this to meet our MACRA, okay? The changes coming to 2018, so pay attention to these areas. You know, ultimately, CMS wants you to be successful. They're going to continue to look for ways to reduce your burden and simplify this program. So there is a new exclusion for a handful of our measures this year. So for MH, depression remission, PREV 5, breast cancer screening, your PREV 6 is colorectal, and hypertension. On those 4 measures, there is a new exclusion, and I'm going to go ahead and read that for you right now, and you will see it in these slides as we go forward, but I want to make it very clear up front. So for individuals 65 and up residing, key term there, residing in a long-term care facility, including nursing homes, and is to exclude individuals who may have limited life expectancy and increased frailty, where the benefit of the process may not exceed the risks. These exclusions are not intended as a clinical recommendation regarding whether the measure process is inappropriate for specific populations. Instead, the exclusions allow clinicians to engage in shared decision-making with a patient about the benefits and risks of the screening when an individual has a limited life expectancy. Basically, in a nutshell, 65 and up, if they're living or residing in a long-term care facility. They are no longer going to be applicable for these 4 measures. For BMI, there's just a small change on our look back period or our previous encounter period. Like I said, nothing major, just those small changes for us. All right, so eligible professionals. I know that you hear eligible professionals, that term thrown out a lot when we're talking about quality measures. Basically, this is referring to is anytime your patient comes in to the doctor's office, sees one of these eligible professionals on this list, you should be collecting quality measures on that patient, plain and simple. All right, here are your quality measures. Like I said, should look very similar, if not exactly the same to last year, your first 7 here. And then you've got 8 through 15 here. We are going to jump right into it. Medication reconciliation post-discharge. Everybody loves this one, right? This is a little bit more, one of our more involved measures. This measure is to be submitted at an outpatient visit occurring within 30 days of each inpatient facility discharge date during the performance period. There is no diagnosis associated with this measure. It may be submitted by eligible clinicians who perform the quality actions described in the measure. So, your denominator here, and I know there's a handful of submission criteria as you're looking at this going, oh my gosh, all this information. All you need to know for medication reconciliation is that patient is 18 or above. Right, you're looking here at your denominator criteria, your patient 18 or older, they have an appropriate encounter CPT code during the measurement period, and patient discharged from an inpatient facility within the last 30 days. Oh, sorry, guys. Your denominator exclusion, which you'll see on most of these, anytime your patient has hospice services during the measurement period, they are not going to be eligible for the measure. So here we have our numerator submission medication reconciliation conducted by a prescribing practitioner, clinical pharmacist, or registered nurse on or within 30 days of a inpatient discharge. And you'll see there's a big long definition of medication reconciliation, a number of different ways that the documentation can be made in the patient's chart. So if you have any questions about whether or not your documentation is acceptable or how you're reviewing your list, I would read through this here. Here you can see your numerator note. Medication reconciliation should be completed and documented on or within 30 days of the discharge. If the patient has an eligible discharge but medication reconciliation is not performed and documented within 30 days, then you submit this 111F with 8P. That is no good, guys. We want to make sure that we are billing any codes that are going to meet our performance measure. So basically what that means is there are CPT codes built into this program that you can use to show Medicare that your measure has been met. So if you're billing this 111F, basically you're saying that you met your performance for medication reconciliation. If you put an 8P on the end of that CPT code, you did not complete that measure. That is no good. You guys want to discuss different ways of billing and collecting your quality measures through claims. We can discuss that at a later time. So again, we see the inpatient discharge of your patient 18 years of age or older, and they are seen within 30 days of that inpatient discharge for an in-office visit, and that office medication list was reconciled with the inpatient discharge medication list. There are some operational tasks here for this measure. More or less, the biggest concern here is you want to know how are you going to be notified of that inpatient discharge. So really, this is going to be different for everybody's facility. something that maybe, your front desk person should be asking anytime a patient checks into the office. Have you been seen or discharged within the last 30 days from a facility? Same thing for the care coordinators. If you guys are doing care coordination in your office, you make a phone call, your coordinator makes a phone call to that patient. They should be asking that question almost immediately on that phone call and finding out if that medication reconciliation needs to be done. Boom, one down. All right, guys, fall risk assessment. Your denominator, all patients age 65 years or older who have a history of falls, and a history of falls being defined as 2 or more falls in the past year or any single fall with an injury in the past year documented in the patient record. So your patient denominator is age 65 or older, they have that appropriate CPT code, and screened for future fall risk, documentation of 2 or more falls in the past year or a single fall with an injury, and they are not in hospice. Your numerator, any of those patients where that fall risk was completed within 12 months. You have a numerator instruction there simply saying that components don't have to be completed during one patient visit, but should be documented in the medical record as having been performed. You see your numerator options there showing whether your performance was met. If you have a denominator exception here on this one, for any medical reasons, for the patient not completing a fall risk, if they are not ambulatory, they are bedridden, immobile, confined to a wheelchair, any of those reasons there, they would be a denominator exception and excluded from that population. A handful of definitions. Could have, if any had any questions on those for what is considered in a fall risk assessment, you can see that there. All right, moving on to diabetes, hemoglobin A1C, poor control. This is our inverse measure, guys. So this one's a little bit different. Patients 18 to 75 years of age with diabetes with a visit during the measurement period. So this one does have a diagnosis with it. So your patients are 18 years of age to 75 with a diagnosis of diabetes. So you have your age criteria, your diabetes CPT code, your eligible encounter CPT code, and your patient is not in hospice. So patients whose most recent A1C level is greater than 9, these people are going to be where our performance is met. We want to see the bad numbers, basically. So what an inverse measure is saying is a lower calculated performance rate of this measure indicates better clinical care or control. The performance not met numerator option for this measure is the representation of the better clinical quality or control. So when you look down there at your numerator options and you see your performance met, your most recent hemoglobin A1C should be greater than 9. Then you see your performance not met option if it is less than. So again, they have to have that diagnosis of type 1 or type 2 diabetes, age 18 to 75. Their A1C is greater than 9, and we are going to get that in a composite score with the diabetes eye exam. So something to remember on this measure as well. Ranges and thresholds do not meet criteria for this indicator. A distinct numeric result is required for numerator compliance. So we have to know what their actual hemoglobin A1C percentage is. We do need to see those numbers documented in the charts. Who can perform this measure? This measure may be reported by clinicians who perform the quality actions described in the measure based on the services provided and the measure-specific denominator coding. Also, notice down there, documentation of the most recent HbA1c may be completed during a telehealth encounter. So your diabetes eye exam will be that composite score with the one that we just looked at. So your denominator, patients 18 to 75 years of age with diabetes. Again, they have to have that diabetes diagnosis during the measurement period, the appropriate encounter, and not in hospice. So for your numerator on this one, patients with an eye screening for diabetic retinal disease. This includes diabetics who have had one of the following: a retinal or dilated eye exam by an eye care professional in the measurement period, or a negative retinal or dilated eye exam and no evidence of retinopathy by an eye care professional in the year prior to the measurement period. And I think you probably noticed there a couple times it does say by an eye care professional. So we want to make sure in this case that they are seeing the appropriate doctor. So they are diagnosed with type 1 or type 2 diabetes, 18 to 75, and have had a retinal or dilated eye exam during the measurement period, or a negative retinal or dilated eye exam in the 12 months prior to the measurement period. Here are your numerator options showing you whether your performance is met. So any of these, and then you can see down there where your performance is not met, the dilated eye exam was not performed and no reason was specified. You are not in compliance. Again, take note, the intent of this measure is for the patient to have a retinal or dilated eye exam performed by an optometrist or an ophthalmologist. So make sure they are getting the appropriate eye exam by the appropriate eligible professional. And then this measure is just a once per measurement period for patients with the diabetes diagnosis, and it may be completed during a telehealth encounter. All right, controlling high blood pressure. And this is one of those that has that new exclusion this year, so we want to remember that. In reference to the numerator element on this measure, only blood pressure readings performed by a clinician in the provider office are acceptable for numerator compliance with this measure. Do not include blood pressure readings that meet the following criteria. So if the blood pressure is taken at the patient's home, no good, or taken the same day as a diagnostic test or diagnostic therapeutic procedure that requires a change in diet or in medication on or the day before the test or procedure, with exception of fasting blood tests. Then in an instance where no blood pressure is recorded during the measurement period, that patient's blood pressure is assumed not controlled. And down there at the bottom, it's just talking about that new exclusion. So here we see 18 to 85 with a diagnosis of essential hypertension. So they have to have that hypertension diagnosis within the first 6 months of the measurement period or any time prior. So your age criteria, your diagnosis of hypertension, eligible patient encounter, and then your denominator exclusions, again, if they're in hospice services, or a documentation of end-stage renal disease, dialysis, renal transplant before or during the measurement period, or pregnancy, denominator exclusions there, or that patient is that 65 years or older residing in long-term care. For the numerator, now we want to make sure we're really clear on this one, guys. So patients whose blood pressures at the most recent visit is adequately controlled, systolic blood pressure less than 140 and diastolic less than 90 during the measurement period. These two pressure values must be submitted separately. 140 over 90 is out of control. 139 over 90, out of control. 140 over 89, out of control. It has to be 139 over 89. Both of those numbers have to be below the 140 over 90. So again, we see that diagnosis of hypertension, 18 to 85 years of age, and blood pressure adequately controlled within the measurement period. You see your numerator options there for performance met and not met. And again, as you can see, they're broken out. Most recent has to be less than, not equal to. So just remember that. That one can get a little bit confusing. Again, if we can't say it enough, both diastolic and systolic must be reported separately. If there are multiple blood pressures on the same date of service, use the lowest systolic and the lowest diastolic blood pressures on that date as a representative blood pressure. And then it can be reported just once per measurement period for those patients with hypertension. All right, IVD. Patients aged 18 years or older with a visit during the measurement period who had, let's go back here so I can remember what all these are, had acute myocardial infarction, coronary artery bypass graft, or percutaneous coronary interventions in the 12 months prior to the measurement period, or who have an active diagnosis of ischemic vascular disease, IVD, during the measurement period, and who had documentations of the use of aspirin or another antiplatelet during the measurement period. So again, patients aged 18 years or older, they have the appropriate diagnosis. You see all these CPT codes. I know some of you are looking at this going, my brain is spinning. Teresa's looking at this smiling. So we have those diagnosis codes for the appropriate diagnosis as well as the appropriate encounter code. Then your exclusions down there at the bottom. Of course, for those hospice patients or patients who had documentation of the use of an anticoagulant medication overlapping the medication year. So here are a list of anticoagulant medications. Now, of course, this may not be a full list. If you have patients on any other anticoagulants and you have questions about whether or not it would fall into this category, let us know and we will look into it for you. Again, here's your numerator. Patients who have an active medication of aspirin or other antiplatelet during the measurement year. Numerator options down there at the bottom, performance met, performance not met. 18 years of age or older with the diagnosis and are on aspirin or another antiplatelet. How often is the measure reported? Once per year. The performance period of this measure is 12 months from the date of service. Can be documented use of aspirin or another antiplatelet can happen during a telehealth encounter. All right, next one, breast cancer screening. Denominator, women aged 51 to 74 years of age with a visit during the measurement period. This one has a little bit of a look back period on it. The intent of this measure is that starting at age 50, women should have one or more mammograms every 24 months with a 3-month grace period. It talks about the exclusion there. Then you can see that's the new nursing home exclusion there that it gets into after that denominator. So again, here's your criteria, 51 to 74 on the date of encounter, your eligible CPT code, your denominator exclusions here for this one, women who had a bilateral mastectomy or who have a history of bilateral mastectomy or whom there is evidence of a right and left unilateral mastectomy excluded from the population, or in hospice service, or that 65 and up residing in long-term care. So here, if they have had one or more mammograms within the measurement period or 15 months prior to the measurement period. So the measure's 27-month look-back period applies to women 52 to 74. The numerator looks for a mammogram anytime on or between October 1st, 27 months prior to the measurement period, and December 31st of the measurement period in order to capture women who had a mammogram every 24 months per clinical guidelines with that 3-month grace period. So just remember to keep that in mind when you're doing these screenings. Colorectal cancer screening. Patients age 50 to 75 who have had a visit during the measurement period. They have that appropriate CPT code. They are not in hospice care nor in long-term special needs. Also on this one, an exclusion, patients with a diagnosis or past history of total colectomy or colorectal cancer, excluded from the population. So the numerator here, patients with one or more screenings for colorectal cancer. The appropriate screenings are shown below here. You have your fecal occult blood test, flexible sigmoidoscopy, colonoscopy, CT, or a FIT DNA. Any of those are acceptable screenings for colorectal cancer. You see your numerator options below. Easy peasy on this one, 50 to 75 and screened for colorectal cancer. All right, here we go. PrevCare and screening for the influenza immunization. This is one that we should be really focusing on right now, guys. We are in flu season. If nobody's noticed, you guys haven't had people coming in with the flu, have you? So on this one, all patients aged 6 months or older seen for a visit during the measurement period. For the purposes of the program, in order to submit on the flu season 2017 to 2018, the patient must have a qualifying encounter between January and March. In order to submit on the flu season for 2018-2019, the patient must have a qualifying encounter between October and December 31st of 2018. A qualifying encounter needs to occur within the flu season that is being submitted. Any additional encounters may occur at any time within the measurement period. So you'll see there you've got your age, criteria for your visits, and then your patient encounter codes, and they're kind of put out there between for your certain time frames. So numerator, patients who received an influenza immunization or who reported previous receipt of an influenza immunization. Previous receipt being a receipt of the current season's influenza immunization from another provider or the same provider prior to the visit to which the measure is applied. So guys, they can go to Walgreens and get this shot. They can go somewhere else and get this shot. We will be able to see that in your data on the portal. So we'll be able to track that, and we'll know if they went to Walgreens and got that flu shot. Here are your numerator options. And you'll see on this one, here note on the denominator exception, if the influenza immunization was not administered for reasons documented by the clinician, there was a patient allergy or a medical reason. On this one, guys, the patient can flat out decline the vaccine, or for some reason, vaccine is not available. That's a denominator exception there as well. Here's our little flow chart, 6 months and older with that visit. They received their immunization or had a previous receipt. Pneumococcal. All right, patients age 65 years or older with a visit during the measurement period. This measure assesses whether patients 65 years of age or older have ever received one or more pneumococcal vaccinations. Your exclusion here, patients received hospice anytime during the measurement period. Again, this one is for patients who have ever received a pneumococcal vaccination. So Mr. Jones could have gone to the VA hospital back in 1950, and he remembered that that pretty little nurse gave him his flu shot. That's all he can remember. That's perfectly fine, guys. As much detailed information as you can get. Mr. Jones went to the VA in 1950 and got his pneumonia vaccination. Here we see when does the pneumonia vaccination need to be completed? Once per measurement period for patients seen during the period. It's not limited to the measurement period. So again, this is a lifetime measure. They can have gotten the pneumonia shot any time within their lifetime, not just within the performance period. And the vaccine can be provided in any setting and may be completed during a telehealth encounter. All right, BMI, and here is where we can take a look and see, I think it shows here, percentage of patients age 18 years and older with the BMI documented during the current encounter or during the previous 12 months, and with the BMI outside of normal parameters. A follow-up plan is documented during the encounter or the previous 12 months of the current encounter. So this is where we see that small change in BMI this year, guys, whereas last year it said 6 months here, the previous 6 months. This year we've got a year. Your normal parameters you see there for BMI, 18 years or older and a BMI of greater than or equal to 18.5 up to 25. So that does not include 25. It is 24.99999 is your cutoff there. You have your denominator being all patients age 18 or older on the date of the encounter with at least one eligible encounter during the measurement period. You have your appropriate CPT codes, your BMI or your denominator exclusions, BMI not documented, documentation, the patient is not eligible for BMI calculation, or BMI is documented as being outside the normal limits. Follow-up plan is not documented, documentation of the patient is not eligible. So really, if the patient wouldn't be eligible for a handful of reasons, we'll look at that here in just a second. Numerator is your patients with a documented BMI during the encounter or during the previous 12 months, and when BMI is outside normal parameters and a follow-up plan is documented during the encounter or during the previous 12 months of the current encounter. And here you have some numerator instructions. This gets a little bit more specific as to what they are looking for. Shows you the definition of BMI, and then the follow-up plan, what exactly they're looking for when it comes to a follow-up plan. May include but not limited to documentation of education, any diet or nutrition, exercise plans, anything like that can be considered a follow-up plan. So when we're talking about people that are not eligible for BMI calculation or a follow-up plan, these exclusions, a patient is not eligible if one or more of the following reasons. The patient is receiving palliative care on the date of the encounter or any time prior to the current encounter, patients who are pregnant, or patients who refuse the measurement of height and or weight or refuse follow-up at any time during the measurement period. These people would be denominator exclusions. Denominator exceptions, patients with a documented BMI outside normal limits and a documented reason for not completing the BMI follow-up plan during the current encounter. These are going to have medical exceptions, really. Basically, elderly patients that are ill, have any mental diseases or nutritional issues that may be causing them to gain or lose weight, or that fluctuation would jeopardize or be detrimental to their health. Here you'll see your performance met, not met, numerator options, and then your denominator exception there in the middle. BMI is documented as being outside of normal limits. Follow-up plan is not documented for specific reasons. And there's your workflow, 18 years or older, documented BMI at the current encounter or during the previous 12 months, and a BMI outside normal parameters that has a follow-up plan during the encounter or during the previous 12 months. Again, here is your definition of a follow-up plan. let's move on to screening for tobacco use and cessation intervention. The listed denominator criteria is used to identify the intended patient population. So there is a handful of different submission criteria here. You can read through those. Ultimately, all patients aged 18 years or older seen for at least 2 visits or at least 1 preventative visit during the measurement period. So your denominator criteria, your patient's 18 years or older, they have that eligible CPT code there, or at least 1 preventative encounter during the performance period qualifies as well. And then this is going to go through each of your numerator submission criterias, and we're not really going to dig real deep into that right now, guys. If there's any questions on that, we can dive into it a little bit deeper on a later date. But you really get the idea there. It goes into the submission criteria for number 2. There's got some definitions, and then your submission for criteria number 3. Gives you a brief little clip about tobacco cessation intervention. Really what that is it's a brief counseling, 3 minutes or less. For the purpose of this measure, the brief counseling qualifies for the numerator. Here are your numerator options, and you can see those codes there. 18 years or older, screened for tobacco use 1 or more times within 24 months, and received cessation counseling intervention if identified as a tobacco user. All right, screening for depression and follow-up plan. All patients aged 12 years or older before the beginning of the measurement period with at least 1 eligible encounter during the measurement period. So your denominator codes here, your encounter codes, your denominator exclusion, stating that the patient has an active diagnosis of depression or has a diagnosed bipolar disorder. Therefore, the screening or follow-up is not required. Those people are going to be denominator excluded. For your numerator, patients who are screened for depression on the date of the encounter using an age-appropriate standardized tool, and if positive, a follow-up plan is documented on the date of the positive screen. So you can see there it goes into a little bit more depth on your numerator instructions. Some definitions here as far as what it means in terms of screening and your standardized tool. I think a lot of us use a PQH9, but there are a handful of different tools, screening tools you can see here for different age groups that are acceptable. So a follow-up plan for this measure means documented follow-up plan for a positive depression screening must include 1 or more of the following. So you can see additional evaluation for depression, a suicide risk assessment. These are all things that must be included in the follow-up plan, or options of things that could be included, let me say. Here are your denominator exclusions and exceptions. So for patients that have an active diagnosis of depression prior to any encounter during the measurement period, they are not eligible for the depression screen or follow-up plan. Or if they have a diagnosed bipolar disorder prior to any encounter during the measurement period, also an exclusion. Patients with a documented reason for not screening for depression, these are exceptions. So the patient, for whatever reason, refuses to participate, or if we are in an urgent situation where time is of the essence and delaying this treatment would jeopardize the patient's health, or situations where the patient's functional capacity or motivation to improve may impact the accuracy of the results of standardized depression assessment tools. For example, certain court-appointed cases or cases of delirium. So these would all be reasons why they would be an exception from your denominator population. Again, 12 years or older, screened for depression on the date of the encounter using an age-appropriate screening tool. And if it is positive, there is a follow-up plan documented on the date of the positive screen. So remember that. All right, statin therapy for the prevention of treatment of cardiovascular disease. This is a fun one, right? So there are 3 submission criteria for this measure as well. I'm really not going to get into it again on this one really deep. You guys can do that on a case-to-case basis. Your denominator, patients aged 21 years or older at the beginning of the measurement period with a clinical diagnosis. So you can see your definitions there for cardiovascular disease. And then again, it goes through each of your criteria. So your patient's age there, your encounter code, and they were previously diagnosed or have an active diagnosis. Your denominator exclusions, patients who have a diagnosis of pregnancy or are breastfeeding, or who have a diagnosis of rhomboid rhabdo. I think it's a shorter version of that. Again, it goes through all those numerator submission criterias. Patients who are actively using or receive a prescription for statin therapy at any point during the measurement period. That's your first one. There it gives a definition of statin therapy. You can see your denominator exceptions for your active liver or hepatic disease or inefficiencies. Here it talks about end-stage renal disease, and you'd see exceptions and exclusions for the complete list on that. Your numerator options here, your performance met, when patients who are currently taking a statin therapy received an order or prescription for it. Your exception there, medical reasons for not currently being a statin therapy user, or they receive an order or prescription for statin therapy. For example, patients with an adverse effect, allergies or intolerance, or patients who are receiving palliative care, patients with an active liver disease or that hepatic disease, or a ESRD there, which you said you saw the definition for that previously. So those are all reasons for denominator exception here. And then again, like I said, it's going through all those different submission criterias there. We're just going to kind of buzz through all this, guys. Getting close on time. I think we're going to be just about right. Again, you'll see your numerator options for that final submission criteria. Here is your list of statin medications. And again, if there's something on there that you don't see, always ask. If you don't know, ask. All right, your patients that are at a high risk category for cardiovascular events, prescribed or were on a statin therapy during the measurement period, and you have those 3 different submission categories. All right, depression remission at 12 months. I think this is our last measure, guys. Patients age 18 or older with a diagnosis. Again, this one's a diagnosis driven of major depression or dyspnea and an initial PHQ-9 score of greater than 9 during that index visit. The denominator identification period. So on this one, it says the period in which eligible patients can have an index event. The denominator identification period occurs prior to the measurement period and is defined as 13 months to 1 month prior to the start of the measurement assessment period. The denominator identification period is from, and you can adjust these accordingly if we're not in the right year, but for patients with an index event, there needs to be enough time following the index date for the patients to have an opportunity to reach remission at 12 months. So the index date, the date on which the first instance of the evaluated PHQ-9 is greater than 9, and they have that diagnosis that occurs during the denominator identification period of November 2016 to 10/31 of 2017, so prior to. The measurement assessment period, the index date marks the start of the measurement assessment period for each patient, which is 13 months in length to allow for a follow-up PHQ-9 between 11 and 13 months following the index date. The assessment period is fixed and does not start over with a higher PHQ-9 that may occur at a different index date. So you have your patients age 18 years or over, their diagnosis code, they have their patient encounter code, and they have that index date PHQ-9 score of greater than 9 during the 12-month identification period. Any exclusions are patients with an active diagnosis of bipolar at any time prior to the end of the measurement assessment period, or patients with an active diagnosis of personality disorder anytime prior to the end of the assessment period, or patients who died anytime prior to the end of the assessment period, kind of noticing a theme here, or patients who received hospice or palliative care service anytime during the denominator identification period or measure assessment period. And I'll let you guys read that last one on your own. Patients who achieved remission at 12 months as demonstrated by a 12-month PHQ-9 score of less than 5 are going to fall into your numerator. The definition of remission, a PHQ-9 score of less than 5. So that 12 months is referring to the point of time from the index date extending out 12 months, then allowing a grace period of 30 days prior to and 30 days after this date. The most recent PHQ-9 score is less than 5 obtained during this 2-month period is deemed as remission at 12 months. So you have that grace period on both sides there, guys. Values obtained prior to or after this period are not counted as numerator compliant or in remission. So if you're doing that PHQ-9 at 12 months, but you're really doing it at 10 months, it doesn't count. And if you've got that 30 days past your 12 months, so if you wait more than 30 days, it doesn't count. You got to get it done in that 30-day grace period prior to or post 12 months. 18 years of age or older with major depression or dyspnea and an initial PHQ-9 of greater than 9. So 18 years or older with the diagnosis and who demonstrate remission at 12 months with a PHQ-9 of less than 5 for newly diagnosed or existing depression. Here is an example of a PHQ-9 questionnaire. All right, guys, I know we covered a lot of information today. And like I said, if you didn't get a chance to print these handouts prior to the start of the webinar, they are in that window pane over there if you get to them. Otherwise, we will send out the slide deck as well as a YouTube link for the webinar. Remember, if you have any questions, reach out to Teresa and I. Make sure we're remembering all of our PHI. So if we're talking about anybody in particular, we want to do that secure email or give us a call. Let's not transfer any patient information over email. And just remember, any upcoming educational webinars that we'll have going forward, even if you guys can't attend, please do make sure that you're signing up for those. That way we know to get you that web link and the slides. If you're not able to attend, we can get those to you at a later date. I'm trying to think of anything else I missed. If you guys, like I said, have any questions, reach out. I know you've probably got a lot to do, so I'll let you get at it. And we will be talking with you guys soon. Thanks. Have a great day.